Good afternoon, everyone. iTech India welcomes all the participants for today's NDLS session. Today's topic is intensified case finding, follow-up, and reporting of HIV-TB co-infected cases. We have with us Dr. B. Ravi Kumar, sir. Dr. B. Ravi Kumar, sir, is a public health specialist with more than 2 decades of experience in implementing large-scale public health initiatives. He has worked in close collaboration with the National AIDS Control Organization, Ministry of Health and Family Welfare, Government of India, as well as various donor agencies. We welcome you, sir, for today's session. Participants, to please note that you will have to put your questions in the chat box. All the questions will be taken at the end of will be addressed at the end of the session. Over to you, sir.
Thank you, Swetaji. And good afternoon, each and every participants who are attending this NDLS session on intensified case finding, follow-up, and reporting of HIV-TB co-infected cases. So we'll go into the session now. So end of the session, the participants will be able to understand like the relation between the HIV-TB co-infection, the TB screening modalities and diagnosis, and how do we manage the TB among PLHIV. And we also be touching more focus, we'll be putting more focus on tuberculosis preventive therapy based on the revised guidelines from NACO, the revised guidance on the tuberculosis preventive therapy, and the recording and reporting tools with again more focus on how do we actually take up this in the search portal. So we just a second, just hold this, hide this. Yeah. So we all know that the HIV-TB co-infection is like the TB is the most common opportunistic infections among the PLHIV, and 3 to 10% of the persons develop TB among the TB infected when we look at the PLHIV. So the mortality is very high among the PLHIV compared with the HIV negative or TB patients. The recurrence of TB and the long-term post-TB mortality among PLHIV are extremely high. So the relation, so what happens when the TB is infected in a HIV positive person? So inflammatory response is no very high among the which causes the replication of the HIV, and there is a rapid progression of the disease. So the as I said, the TB is the most common opportunistic infections among the HIV/AIDS cases, and the mortality is also very high due to TB among the HIV patients. So if you look at the comparison between the proportion of the people among the general population and among the PLHIVs. So around 80 to 20% among the general population suffer from the pulmonary tuberculosis, and 20% among the extrapulmonary tuberculosis. So when you compare that with the HIV patients, 60% of the patients suffer with are diagnosed with the pulmonary tuberculosis, and 40% are diagnosed with the extrapulmonary tuberculosis. The increased risk is very high among the PLHA. Increased of TB is very high among the PLHA, which is around 16 to 21 times. So we look at some of the important strategies for the prevention management of TB and PLHA. So can you please quickly put in the chat box what are some of the important strategies for the prevention management of TB and PLHA? So this is the session will be more focusing on how do we actually take care of our own patients coming to the ART center. So we have to be aware of some of the strategies of prevention management. So what strategies can we know can be considered when we talk about the prevention and management? So quickly in the chat box, please. Just take 1 or 2 minutes. Don't worry about right or wrong. Just keep putting your thoughts on what strategies can be implemented in prevention of the TB among PLHIV, whom we see at our own ART centers. So TPT is excellent. Okay. Yeah. Yeah. IPT and TPT 4S screening. Very good. Then adherence, we take it. Yeah. Maybe to the ART and ATT. We'll take that. Yeah. Okay. What strategies can we look at, or can we think of the prevention of TB? Yeah, we this already covered, Dr. Suneha, forest screening and TPT. So any other measures apart from forest screening and TPT? So you're all actually missing out some of the important points that we usually take care at the RT centers. Early diagnosis is excellent. So early diagnosis, again, we go back to and link it to the forest screening. So that's what we call as the intensified case finding, right? Fast tracking, yeah, fast tracking is excellent. Again, linked to the forest screening. Any other important factors that we need to consider? Leave about TB, any airborne infection control that we need to take care. Okay. S- Yeah, fast track, TPT, forest training, all, yeah, good. So let's get into this. So we look at some of the strategies here. So intensified case finding is the most important part of it, where we actually have seen in the chat box people talking about the fast tracking and referral of the symptomatic patients for the CBNAT testing or TrueNAT testing or whatever the testing methodology that is available at the ART center or at the DMC. And any other appropriate investigation. So apart from the NAT testing, we also look at other investigations for the diagnosis part. So intensive case finding is the most important thing. Effective treatment. So people, putting in the chat box. So they actually know effective treatment of active TB. So that is the most important. So once you diagnose the TB, putting them on treatment and ensuring the completion of the ensuring the course of completion of the TB treatment, that is most important. Prophylaxis. I think the CPT prophylaxis, people have missed out on the commonest prophylaxis that we usually give on each and every TB patient. Early initiation of ART, people have touched that. So early initiation of ART, so the previous guidelines have changed. So now we start, along with the ART, we start the TB treatment, except for in some specific situations that we'll discuss in the session. And TPT, the most important thing, tuberculosis preventive therapy. And the other most important thing is the airborne infection control in the health facilities. So these are some of the strategies that we usually talk about when we say the prevention of TB among PLHIV, which are specific to the PLHIV. Maybe we can talk about our own ART centers, what care needs to be taken and what strategies needs to be adopted when we talk about the prevention part of it. So coming in the TB screening and diagnosis. So So the four symptom screening, we are all aware that the four symptom screening has to be done for each and every patient, right? So we look at what are the four symptom screenings among the adults and the children. So when we talk about the PLHIV coming to the ART center, the four symptom screening varies from adults to the children. So when we talk about adults, then it will be the current cough, fever, weight loss, and night sweat. So current cough, cough of any duration, that's what we say when we talk about current cough among the adults. Same when we talk about the children, a bit vary among the four symptoms. When we say current cough, so again of any duration, fever, and then when we talk about the adults, it's weight loss. When we talk about the children, it's a poor weight gain, and the history of a contact with a known TB case. Okay, so that is the difference between the screening of the PLHIV when we talk about the adults and children. Okay, so when the patient comes with any of these symptoms, okay, when we say we will look at the flow of how the flow will be there when we how we have to screen in the coming slides. So when the patient complains of any of these positive symptoms, then we start investigate them. So once they say any of these following symptoms, it's not that no all four has to be present. Any of the four symptoms mentioned here among the adults and children. So you have to say yes, then the patient will be investigated for TB and other diseases. So if the TB is suspected, the patient will be treated for TB. Then the patient is not suspected for TB, then they will be considered for the TPT prophylaxis. And if there are any other OIs, then the appropriate treatment will be given, and also the patient will be considered for the TPT. Suppose the patient says no for any of these four symptoms, then they will be evaluated for the provision of the TPT. If there are any contraindications to the TPT, then the TPT will be deferred. But when to screen these patients? So how frequently do you screen these patients? The patients have to be screened during the time of registration, right? When the new patient comes to the ART center, and during the ART initiation, and during every follow-up visit. So this is the most important thing. Like, no, every patient will be coming each and every month. So, sir, last time we have screened these patients. Do we need to screen again? It's not that. Patient has to be screened on each and every follow-up visit, and for the new patients at the time of the registrations. And who will be screening? Like the initial flow that we'll be looking at in the coming slide. So it will the patients will be screened by the care coordinator, the staff nurse, and the counselors, and finally will be evaluated by the SMO and appropriate the referrals and linkages to the testing and the treatment will be taken care by the medical officer. So if you look at the screening flow that happens at the ART center, that as we discussed in the earlier slide, the care coordinator will be screening. They will be asking about the symptoms. If the patient says, I have one of these 4 symptoms, whether it is adolescents or the children, then he will be entering in the green book. Then the staff nurse will put the 4 symptom stamp on that book, and then she will identify what symptoms the patient has and also enters into the green book. Then the SMO will evaluate the patient whether the symptoms are there or not, and then enter in the column white card. And apart from this, we'll look into the flow of how the patients will be referred, based on the operational guidelines that there in the ART center. So in the column 13, the medical officer will be entering about the details of the patient's, no, the 4 symptoms when he visits the ART center. So if you look at the diagnosis part of it, then the medical officer, the ART center determines the patient to be tested, and then the memo will take the final call where the patient needs to be tested and referred back to the patient to the staff nurse for the referral. So the important thing is the maintaining the HIV-TB line list register. So first thing is your patient register will be there, and then based on that, the patients will be fast tracked based on the 4 symptoms, and then the staff nurse will be maintaining the HIV-TB line list where the details will be entered, and then the patient will be referred to the medical officer for further evaluation. So if you look at the entire process, so once the staff nurse fills up the CBNAT referral form, when the patient is said the 4 symptom positive, then the patient will be referred for the CBNAT. If the CBNAT the investigations are not available, the patient will be referred for the DMC for the other relevant investigations. So she will also document the patient details in the column number 11 of the HIV-TB line list, which is the new format which has been revised and shared with all the ART centers. So this documentation has to be done in the as per the new format. And then the patient will be referred to the concerned DMC or the CBNAT for the facility. So once after the patient is advised to come back to the staff nurse in the ART center with the TB report, so the usually, as per the NDEP guidelines, the same day CBNAT report has to be provided, but sometimes for the administrative, for any other logistical delays, there might be a delay. So once the report is ready, then the patient will be referred back to the ART center where the testing reports will be evaluated by the medical officer. So in case the CBNAT testing, usually what happens is the one spot sample is required, but for the spare microscopy, as per the NDP guidelines, 2 samples are no required within 1 hour apart. So and then once the report is ready, if the patient is turned out to be TB positive, then the NICSHA ID will be generated, and then the ART center has to do the updation in the NICSHA portal on a daily basis. In case of extrapulmonary TB, then it has to be other diagnostics like X-ray or the CSF or the FNAC or ultrasound or biopsy might be needed in time in course of the time when all the reports are ready. Then the patient will be evaluated for extrapulmonary tuberculosis, and then the treatment will be initiated. So once the line list is complete, the data manager has to digitize and then maintain it in a soft copy, and also has to maintain it in the NICSHA portal. So this is the flow of the patient at the ART center. So when we look at the recommended approach to the DB diagnosis, once we say that, as we discussed in the earlier slide, that they have to undergo whether the CBNAT or the TrueNAT, if in case if the appropriate specimen is available based on the site. Otherwise, the patients usually will be referred to the DMC wherever the NAT machines are not available. So the patient is NAT positive for Mycobacterium tuberculosis, then we'll be looking into whether the patient is rifampicin, whether the sample is rifampicin resistant on NAT or rifampicin sensitive. So in case the sample is rifampicin resistant, then the patient will be referred to the DRTB center for the first line LPA or the second line LPA and the liquid culture for the drug sensitivity testing. ATT will be decided at the ERTB center and not at the ART center. So we are referring the patients who are resistant, who are rifampicin resistant, who are rifampicin resistant, then they will be taken care of. The ATT will be initiated at the DRTB center. In case the patient is the sample is rifampicin sensitive, then the patient will be referred to the ART center, where the ATT will be started at the ART center and the sample will be sent for the LPA. So, in case this particular sample, once it is diagnosed, once the report has come out as the INH resistance is detected, and the patient again will be referred to the DRT center for the further management. If the patient is INH is sensitive, then the ART center will be taken care. The patient will be taken care at the ART center. So, in case if the NAT is negative or not visible, appropriate specimen is not available at the particular site, then the patient will be evaluated for TB using the appropriate diagnostics tools like the chest X-ray, ultrasound abdomen, or biopsy. And if the patient is negative, negative NAT does not rule out TB. Then, if the TB is diagnosed, then the ATT will be started at the AT center. If the TB is ruled out, then evaluate for the alternate diagnosis. So this is how the approach will be made for the TB or the ART centers. So if you look at the TB diagnose some of the case definitions as per the NTEP. Sorry. So once you say the microbiologically confirmed case, so the presumptive TB patient with biological specimen positive for the acid phos bacilli or positive for the MTB and culture, so they will be considered as a microbiologically TB, confirmed TB case. So clinically diagnosed TB case is presumptive TB who is not microbiologically confirmed but diagnosed with active TB by a clinician based on the X-ray or the histopathology or clinical signs with a decision to treat the patient with a full course of anti-TB treatment. So when we talk about, say, pulmonary TB, any microbiologically confirmed or clinically diagnosed case of TB involving lung parenchyma, trachea, or the bronchial tree are considered as pulmonary TB patients. Extrapulmonary, any microbiologically confirmed or clinical diagnosed case of TB involving other organs other than the lungs, such as pleura, lymph node, intestine, joints, bones. So any part other than the lungs are considered as the extrapulmonary TB. And just to note that the miliary TB is classified as pulmonary TB because the lesions are in the lungs. A patient with both pulmonary and extrapulmonary should be classified as a pulmonary TB patients. So these are some of the case definitions. So when we say when we talk about management of active TB disease, so here also we have some definitions here which we call as the new patient or the previously treated patient. So when we say new patient, a new patient is a TB patient who has never had treatment with anti-tuberculosis drugs or taken it for less than a month. So we call them as a new patients. So the patient here is totally not taken medicines of ATT or at least have taken less than a month are considered as a new patients. It's not that the patient already initiated TTT, but completed less than a month. So he'll be considered as previously treated. It's not that. So new case is someone who is not treated, who has never taken a treatment or taken treatment for less than a month are considered as a new TB patient. So when we talk about previously treated patients who has received 1 month or more than 1 month of anti-TB drugs in the past are considered as the previously treated cases. So these two are most important when we say that the patient is a new patient or a previously treated patients. So when you talk about the management, so new and previously treated cases, whether it is isoniazid, rifampicin sensitive or unknown, okay. So the treatment regimen will be 2 months of intensive course of HRZD daily, so which contains of 56 doses, and treatment regimen in the continuation phase, which is 4 months. So 4 HRE, which is the 3-drug FDC, which contains of 112 doses. I think everyone is aware of HRZE, so isoniazid, rifampicin, pyrazanamide, and ethambutol. And as we all know, the course has to be taken for a complete course prescribed. So 2 months of intensive phase and 4 months of continuation phase, total lasting for a 6 months period. So as we discussed, the PLHAV who are diagnosed with drug-resistant tuberculosis, they will be referred to the DRTB centers for further management of TB. And patients who do not have an appropriate specimen, so they will be offered a standard first-line treatment and followed by the radiological confirmation or clinical confirmation or histopathological confirmation to identify any signs of non-response to treatment. So the daily dose of for adults more than 18 years, I think the self-explanatory slide, but the fixed dose combinations, as we said, like the 4 FDC for the 2 months of intensive phase will be containing the SRZE, and for the continuation phase, it will be 3 FD. So these are the fixed dose combinations based on the weight category. So in case during the treatment period, if the patient increases by more than 5 kg, the most important point here is we usually, sometimes miss checking the weight of the patients who are on the TB treatment. So which is most important is if the patient weight increase by more than 5 kgs and cross the next weight band, then the dosage has to be based on the weight band of the FDC drugs. So this is most important point that needs or the ART staff needs to know, keep in mind that every TB patient has to be checked for weight during every visit, and based on the weight gain, then the course has to be changed. The FDC has to be changed. For the children, pediatric patient up to the age of 18 years. So again, based on the weight band, but exclusively for pediatric patients, the dispersible FDC consists of HRZ and the 2 FDC consists of HR. Okay. So the most important again here is change in the weight bands, which has to be effective on crossing the weight bands irrespective of the quantum of weight gain or loss. And also we need to keep in mind that the patients, for pediatric patients, the FDC ought to be made available under the program. In case some of the ARTSN does not have the FDC, they have to advocate with the district or the state NTAP officials and ensure that the following the FDC are to be available at the ART center. So for the intensive phase, it has to be an FDC of rifampicin, isoniazid, and pyrazinamide, 175, 50, and 150 mg respectively. And ethambutol 100 mg has to be given separately because it cannot be part of the dispersible FDC because of its instability in the combined dispersible tablet preparation. This is for the intensive phase, and for the continuation phase, as we said, it has to be again rifampicin 75 mg and isoniazid 50 mg as an FDC, and ethambutol has 100 mg as again has to be given separately. And as unlike adults FDC, so ethambutol is not part of the pediatric FDC, and it has to be given separately. So this is again one thing to know, important point to remember for the officers when we talk about procuring the drugs for the pediatric patients. So sometimes the TB treatment might be extended in certain situations. So continuation phase will be extended by 12 to 14 weeks in certain forms like the CNS TB or the skeletal TB and disseminated TB, which is based on the clinical discretion of the treating physician. And it will be extended beyond 12 weeks only based on the experts of the concerned field. So it will be taken decision at that level. So in case if the treatment needs to be extended, then maybe a recommendation from the higher authorities of the TB has to be taken and then considered it. And steroids as an adjunctive therapy are useful in the patients with TB pericarditis or meningeal TB with an initial high dose, which will be tapered gradually over 6 to 8 weeks. So the treatment outcomes as per the NTP guidelines, so we have certain treatment outcomes, so cured, treatment completed, and treatment success. Cured is, if I microbiologically confirm the TB patients at the beginning of the treatment who are smear or culture negative at the end of the complete treatment. So they're called the outcome is known as the cured. So when we document this again, so most of the, if you look at the HIV-TB registers, I'm not talking about the HIV-TB line list, but the HIV-TB registers. So most of the times that we actually miss out is one is the ART start date will be there, ATT start date will not be there. Okay, in case if the ATT start date is there, then the treatment completion date will not be there, and the treatment outcome or most of the attempts it will be blank. So this is the most important documentation that the ART staff needs to know, ensure that it is complete. So even though we are entering in the soft copies or the search portal or our own data that we made at the RT center. But the most important is that you have to enter the treatment outcomes in the HIV-TB register. Okay. So when we talk about the treatment completed, a patient who has completed treatment without evidence or failure of the clinical iteration, but with no record to show that smear culture results are biological specimen in the last month the treatment was negative, maybe because the test was not done or because the result is unavailable, or a clinically diagnosed patient, pulmonary or extrapulmonary, who has received full course of treatment. So that means that we don't have a record to show that there is a smear or culture uh, I mean, the testing was on and it was negative for various reasons. So we only say the treatment is completed. So when we say cured, that we have every uh, record to show that the patient is culture smear or culture negative. Okay, so this is the difference between completed and the cured. So when we say treatment success, so either cured or treatment completed or according to the treatment success, but this is not an indicator. This is an indicator, but not an outcome. So again, when we talk about failure, so patient whose specimen is positive by smear or culture, failure to respond, a case of pediatric TB who fails to have microbiological conversion to negative status or fails to respond clinically or deteriorates 12 weeks of compliant treatment shall be deemed to have a failed response, provided alternate diagnosis or reasons for response, non-response have been ruled out. So we call it as a failure to respond to the treatment. So last to follow up, so whose treatment was interrupted continuously for 1 month or more. So this is the terminology that the difference between the ART follow-up and the patient TB follow-up. So continuously more than 1 month or more. So ours is 28 days. So this is the difference between the TB LFU and ART LFU. So not evaluated, a TB patient for whom no treatment outcome is assigned. So this includes former transfer out. So the patient who is on TB and transferred out, so we don't have, is not evaluated because we don't know the outcome of that particular patient. So treatment regimen changed. So on the patient who is on first line TB treatment has been diagnosed as having a DRTB and switched to the DRTB treatment. So died who has patient who has died during the course of the TB treatment. So coming to the management of HIV-TB co-infected patients. So based on the lab reports, the SMO will establish what type of TB the patient has, whether it is a PTB or EPTB, whether it is a drug-sensitive or drug-resistant TB. So all PLHIV diagnosed with DSTB will be initiated on ATT at the ART center. And all the TB co-infected patients will be dismissed 28 days of ATT, along with the CPT, the most important that we usually miss out, giving the CPT prophylaxis from the ART center. And the pill pickup date has to be adjusted based on your ATT schedule. Okay, this is most important because we usually give 1 month of ART pill. So you have to adjust it for the 28 days. The patient has to come back to the ART center to pick up both ATT and ART. So for the DRTB cases, the patients referred to the concerned DRTB center will be ensured by the NTEP, and information will be communicated to the ART staff nurse to complete the recording in the HIV-TB line list and the HIV-TB register. And then the most important role again, the ART counselor will be counseling the patient on no adherence part and possible effects of ATT, and then if needed, a telephonic follow-up of the patients has to be done. If needed, a visit has to be done to the patient homes, ensuring that they are maintaining the adherence part of both ATT and ART. So TB treatment initiation. So once the patient is diagnosed, the stamp as shown here in the picture. Hope every ART center has this particular stamp. Okay. So we'll be classifying the TB, whether it is micro or clinical, it will be there. Okay. And sorry, I'm not the stamp, it's in the white card, the section of the 7 of the white card. So that will be there. So this particular section, you have to ensure that the patient, what type of TB that the patient has. So he'll be entering into this. So, and then the rifampicin status, whether it's sensitive or resistant, has to be clearly marked. And then the stamp should be placed in section 7 of the patient white card. So this particular, the stamp that is there, we were discussed earlier. So that will be placed in the patient white card. Okay. And accordingly, then the patient, the medical officer will be initiating the TB treatment as per the NTEP guidelines at the ART center itself, except for the DRTB cases where they will be initiated at the DRTB center. And the same has to be documented both in the white card and the green book. And all patients will be initiated on a daily ATT at the ART center itself. So as I said in the earlier slide, the most important point is the dates have to be realigned pill pickup dates have to be aligned with the TB pill pickup dates. Okay, so till the course of the treatment. So, and when we talk about no now we are in the phase of the rapid ART initiations also. So when we talk about early ART initiations, will have even has a positive impact on the TB co-infected patients. So which will no reduce the risk of developing active TB in the PLHIV significantly. So ART has to be started as soon as possible, irrespective of the CD4 count, or within as soon as possible. Usually both can be given simultaneously, or minimum within 2 weeks of initiating TB treatment has to be started among no among the people with HIV, except when signs and symptoms of meningitis are present, where it will the TB treatment, the ART will be delayed at least for the 4 weeks, and initiated within 8 weeks after the completion of the TB treatment meningitis is initiated. So corticosteroids, as we discussed in earlier slides, should be considered as adjuvant for the treatment of the TB meningitis. So the only difference here is it has to be started as soon as possible within 2 weeks of initiating the TB treatment. So regardless of the CD4 count. And the other important point is the TB meningitis, it will be delayed at least by 4 weeks and initiated within 8 weeks after the treatment for the TB meningitis is initiated. So patient registration and adherence. So as we discussed, the patient details has to be enrolled in the NICSHI with the data management of the ART centers. The ID will be created by the NDP staff and then given. I think most of the ART centers are also now actually generating the NICSHI IDs. So concerned STS or TB HIV coordinator will identify the treatment supporter for the TB HIV co-infected patients and is responsible for follow-up and ongoing ritual actions from the patients. So if the patient belongs to a different districts, HIV-TB coordinator will coordinate with their counterparts of the other districts for follow-up of the patients, as we do regularly when we actually transfer out the patients to other ART centers or other to the other districts. So district DRTB and HIV-TB coordinators are ultimately responsible, accountable for the treatment support, adherence, and direct benefit transfers for all TB HIV co-infected patients. So the information of both the HIV-TB co-infected patients have to be shared with the HIV-TB coordinator. So this usually happens during your monthly, whether it is ART and DEP coordination meeting. So the data usually on a daily basis will be shared with your district HIV-TB coordinator, who will take care of the direct benefit transfer DBT, and also will be there to support the adherence part of it. Okay, and in case there are other situations where he'll be mostly involved in making the house visits also. So the importance is that you have to share the data with your HIV-TB coordinator. Any adverse reactions identified with the ART staff have to be informed immediately to the ART medical officers or at the peripheral health institutions. And coming to the follow-up, so the sputum follow-up testing by sphere microscopy must be done at the end of the intensive and the continuation phase. And sorry. So this will be done by sputum microscopy at the DMC and not by CBNAT and TrueNAT. So this is the most important. The patient will not come back for again the CBNAT testing. Okay, so they have to be tested at the DMC and not by the CBNAT or the TrueNAT or any other NAT testing. So in case of extrapulmonary tuberculosis patients, they will be evaluated clinically by both diagnostic tests, which were used earlier for diagnosis at the ART by the ART medical officers. And all the follow-up sputum and other examination details must be clearly documented in the TB treatment card, and also has to be in the white card. In case the patient is transferred out to any other ART center, the transfer out form needs to be completed and sent along with the ART transfer out form, along with your NTEP referral transfer out forms. So again, the concerned district HIV-TB coordinators, so transferring out from one district to other, so both of them have to be kept informed about the transfer outs. So coming to the ART regimens in the PLHF receiving, so DTG based regimen is the preferred regimen, okay, for all the first line rifampicin containing ATT. However, since the rifampicin is a potent inducer of the drug metabolizing enzymes and drug transporters, so the co-administration will DTG reduces the bioavailability of the DTG. So this is the reason why the additional dose of DTG 50 mg will be given, which will be taken at an interval of 12 hours with a regular dose of DTG. Suppose the patient is on TLD, Then the dose will be taken in the morning for the TLD, depending on the time of the patient, TLD has been advised. And 12 hours after, the additional dose of DTG 50 mg will be given until 2 weeks after completion of ATT. See, this is again the most important point, which during our observations have come out, that some of the patients were most probably, for some reason, whether the DTG 50 mg is not available at the center, but no, efforts have to be made to ensure that for these patients, the sufficient quantity of DTG 50 mg is available at the ART center till the course of the completion of the treatment for that particular TB patient. So we have to look at how many TB patients that we have at the ART center taking treatment, okay, and how many patients are there on your DTG based regimen. So additional dose of DTG, whether it is available or not. So this is the most important thing. So the DTG has to be continued till 2 weeks after the completion of the ATT. So that much amount of sufficient quantity of DTG has to be procured by the ART center in, in discussions with your ART, in discussions with your SACs. Okay. So if the patient is co-infected with HIV on first line ATT and needs to be co-administered with the boosted protease inhibitors based on ART regimen. So again, rifampicin should be replaced with rifabutin for the entire course of ATT. Again, this needs to be discussed with your NTEP officials for the procurement of rifabutin, because SACs will not usually be procuring this rifabutin. So again, it has to be advocated with your NTEP officials at the district level and the state level in communications with the SACs. So what are the recommendations if the TB is diagnosed in patients who are already receiving ART? So if the episode of TB develops more than 6 months after initiation of ART, ART treatment failure can be considered, which should be based on your CD4 count and the viral load count. So without which we cannot say the treatment failure has occurred. So when we say there is a development and episode of TB after 6 months after initiation of ART, then you need to look at your CD4 count, because any of the patient will be eligible for the viral load testing. After 6 months, then the viral load test has to be done, and then look into whether the treatment failure is actually there. So the development of episode of pulmonary TB after 6 months of ART without immunological evidence of disease progress should not be regarded as a representing ART failure. So the difference between these two is, one is starting the initiation of ART, and before 6 months the patient considered there is a failure, then the CD4 count and viral load count has to be taken into accountability. And if the episode has occurred after 6 months of ART and without immunological evidence, that means the CD4 and viral load, CD4 is good and viral load is suppressed, then we should not regard it as a ART treatment failure. And EPTB should be considered as an indicator of ART failure, although simple lymph node TB or uncomplicated pleural disease may be less significant than the disseminated TB. So these are the important points before actually some patients usually be referring, initiating ART, and then the patient has developed TB. So then we look at whether the patient has completed 6 months or not completed 6 months. And then we then categorize whether the treatment failure has occurred, or usually this is because of, no, there is lack of adherence based on CD4 count and the viral load. So ART for the HIV TB co-infected patients on bedaquiline delamidine. So DTG based regimens should be the ART regimen of choice. This we have discussed before. But for PLHIV on bedaquiline and delaminide also, no, DTG based regimen should be the ART regimen of choice. So PLHIV who are already on 2 ART and DTG based regimen, they should be continued with bedaquiline delamidine containing DRTB regimen. And PLHA with NNRT and PA based regimen, they need substitution of NNRTI PA with DTG in the ART regimen. And PLH requiring a PI based second line, third line ART need coordination between SASEP and the linked DRTB center for considering a non-bedaquiline delaminide duct resistant tuberculosis regimen. In case an effective DRTB regimen cannot be made with BDQ or DLM, then the necessary DRTB regimens using new TB drugs may be given with the PI-based ART, but with intensive monitoring of toxicity, because there is always a chance of prolongation of the QT interval in the ECG. So that's the first phase that we talked about. Some of the strategies, note how we actually diagnose, and then know what are the management strategies that needs to be given, what are the 4 symptom screening, and then what management has to be given for the HIV-TB co-infections. And then we also looked in what regimens have to be given for the patients on different TB, on different ATT regimens. So coming to the most important point, so the tuberculosis preventive therapy, this is again the important strategy. So what we discussed again, that among the steps that needs to be followed the AT center. So the second one is the tuberculosis preventive therapy. First one is identifying the TB patients and diagnosing them and then treating them is the most important, apart from the patients without the four symptom treatment. So that needs to be given the TPT. So what is tuberculosis preventive therapy? So this is a course of one or more ATT drugs, anti-tuberculosis drugs, which are given with the intention of preventing the development of TB disease. So TPT is given to people who are infected with TB bacteria or have been exposed to it and are at a higher risk of TB developing TB disease than the general population. So we consider the PLHIV are at a higher risk of developing TB. So we give them based on the four symptom screening. We start them on the TPT. So this is one of the critical public health measures to protect both individuals and the community from the TB. And this is the key interventions to achieve the NTB targets. So how the TPT works? So TPT is intended to eliminate TB bacteria that have infected the body and can progress to active TB disease. So the technicalities, so boosting the INFA response to a number of TB antigens, so which inhibits the synthesis of mycolic acids and key cell wall constituents and displays a biphasic killing with rapid early bactericidal activity against the actively replicating bacilli. So this also accelerates the sterilizing activity with the two drugs, rifampicin, paragenamide, and thus shortening the regimen duration. So inhibits the translational adaptation by directly binding to the ribosomal protein S1 in non-replicating MTB, and this will only work when there is no evidence of active TB disease. How do we actually rule out the active TB disease? We have seen how the four symptom screening is done, right? So this will only work when there is no evidence of active TB disease. And exactly in a year back, that NACO has shared an OM on the revised guidance on the tuberculosis preventive therapy for PLHIV under NACP. Please remember, this is under NACP. What is the TPT regimens that we use at the ART centers? So, which will talk about the categories of the PLHIV who are there and what is the preferred TPT regimen, okay, and what modifications needs to be done. And it is clearly said, it also clearly says that SACS has to calculate the estimated category-wise number of PLHA who will be eligible for different TPT regimens listed in from 1 to 6 in the OM, and then how the indent has to be prepared and how no the NTP coordinate with the NTP people, and how we actually do a phased implementation of one HAP for PLHV who are more than 13 years of age. So now we go into the PLHV categories, what who are eligible for the 1 HP or different categories of the tuberculosis preventive therapy, preventive treatment under the revised guidance. So category 1 is PLHV who are 13 years of age or older. The what regimen has to be given is 28 days of 1 HP, which contains isoniazid and rifampicin once daily for 28 days. So which we don't need any dose modifications with this particular 1 HP TPT regimen. So PLHIV less than 13 years of age, pregnant and breastfeeding women, and PLHV who are on protease inhibitor based regimen. So the preferred regimen is again the 6 months of isoniazid once daily for 6 months. So INH is preferred here. So only 6 months of INH here. So these are the major categories that we usually have to know. Categorize based on our line list of the PLH or the ART center who are 13 years and older, who are less than 13 years, who are if there are any breastfeeding or pregnant women, and who are there on the protease inhibitor based regimens, and then categorize based on, and then look at what regimens they will be has to be initiated on and what is the stock that is needed for us to procure from the NTEP and SACS. So who should be offered TPT? So adults in more than 10 years. So children aged more than 12 months, infants aged less than 12 months who are in contact with the TB patients. And additionally, children who have successfully completed treatment for TB disease, so secondary prophylaxis. And it is not second. Please note the secondary prophylaxis we have seen in even some of the queries from the field whether the secondary prophylaxis is required for PLHV more than 13 years is not required in 13 years, but it is required secondary prophylaxis required for less than 13 years. So as I said, the TPT has to be offered after ruling out TB disease, regardless of ART, pregnancy, previous TB treatment, immunosuppression, and availability of test for TB infection. So how do we rule out TB disease? We have seen the 4 symptom screening. So adults and adolescents more than 10 years without current cough, fever, weight loss, or night sweats are unlikely to have TBC and should be offered TPT. children living with HIV more than 12 months of age who do not report poor weight gain, current cough, history of contact with the TB case, fever, are unlikely to have active TB and should be started on TPT. Infants aged less than 12 months living with HIV who are in contact with a person with TB and who are unlikely to have TB and appropriate clinical evaluation should be receive the TPT regimen. So, mandate is a test for TB infection is not a requirement for initiating TPT among PL-HIV. So, this is one again the uh, delays that we usually look at the ART center that the TB infection is not ruled out, so we are not initiated on TPT. So, these 4 symptoms are good enough for you to rule out TB disease and start initiating TPT. So 4 symptom screening. So we have discussed this slide earlier. So not going into depth of this, just we look into yes and no. So if the patient says any of the 4 symptoms, then the TB is diagnosed, treat for TB, not TB, follow-up is considered for TB. So if there are any other possible infections, so give appropriate treatment, again consider TB. So the patient doesn't report any of these things. So if there are any contraindications for TPT, defer TPT. So no contraindications, start TPT. Okay, so when it should be initiated for all the newly registered PLHV, start both ART and TPT at the same time after excluding active TB disease. We have seen how to exclude the active TB disease in the earlier slide. And for PLHV who are already on ART, who are not received TPT, ever should be initiated on TPT at the earliest. So we are not going in depth into the special situations of the TPT, right? But if at all interested, the operational guidelines, treatment guidelines, you have seen the special situations where how the TPT has to be initiated. The mobile guidelines and are need to be updated, but at least you can refer the treatment guidelines. So for the special situations. So some of the contraindications are active TB disease, active hepatitis, if the patients are complaining of regular and heavy alcohol consumption. If there are signs and symptoms of peripheral neuropathy, rule out persistently rule out whether it is drug induced or no, or the patient has some other neurological issues. So they have to it has to be ruled out. And there is a persistent tingling, numbness, and burning sensations in the limbs. Okay, PLHV who have completed DRTB treatment, concurrent use of other hepatotoxic medications, allergy or known hypersensitivity to any drugs being considered for the TPT. So these are some of the contraindications. So previous contraindication, there were some changes to the previous guidelines. So that have been removed from the list is poor adherence to the CPT is not a contraindication. And poor understanding by the IPT by the guardian is not a contraindication. So contacts of MDR-TB is not a contraindication for the TPT. So these were there in the earlier guidelines. So they have been removed from the list of contraindications. So assessment, how do we do the assessment? So we look in the personal history of medication and the LFT investigations. So personal history, you have to take the personal relevant history. If there is a pregnancy or contraceptive usage, look into the presence of any comorbidities, and then if there is substance use of alcohol or oral injecting drugs. When you talk about the history of medication, if there are any history of hepatotoxic medications, you have seen in the earlier slide, if there is a history of current use of hepatotoxic medications, that needs to be taken into consideration. Allergy or known hypersensitivity to any other drugs being considered for the TPT. So these are the history of medication that needs to be assessed before initiating the TPT. And based on the liver function test, which is not a mandatory, but you suspect the patient has no given a history of substance abuse of alcohol, then you can do a no liver function test, baseline testing in individuals with risk. So with the abnormal baseline results, where you have an ALT, AST is raised 3 times more than the upper limit of the normal in the presence of symptoms, or more than 5 times in the absence of the symptoms. So where you need a clinical judgment and start the TPT. So 1HP as a treatment option. So we have seen who are eligible is more than 13 years. Any PLHAV who are more than 13 years. The medicines that we have in the 1HP is isoniazid and rifampicin, and the duration is 28 days. So total duration and frequency is once daily. Pregnancy, we don't usually take 1HP as a TPT option. So interactions with ART, so it is contraindicated with all PAs. That's the reason we say that all PAs patients on PI-based regimen has to be initiated on INH. So contraindicated is all PIs, nevirapine and TAF. And there is no adjustment required for TDF and if average. Okay, dolutegravir and raltegravir. So adverse drugs, some of the adverse drug reactions, hepatotoxicity and hypersensitivity reactions, rash, GI upset, and discoloration of the body fluids. Uh, Peak concentration is increased when given with a meal. So eligibility is the most important. Just remember that more than 13 years, excluding pregnant women and those on the PI-based regimen. Uh, for the TPT regimen for the PLHAV who are in contact with the drug DRTB case. So PLHAV in contact with the DRTB case who has INH resistant but is rifampicin susceptible, then the course is 4 months daily rifampicin. PLHF having contact with TB patient who was MDR rifampicin resistant but is fluoroquinolone susceptible, then 6 months of daily levofloxacin. So 6-LFX is the course that is given for the TPT regimen as a TPT regimen for the patients in contact with the DRTB patients. So, but the proper documentation of history for TB among family members and close contacts and drug resistance of index TB patients should be done in your white card and the TB card. So dosage, so based on the dosage of the pill, the illustration gives you the number of pills that needs to be taken based on the dosage available. So once daily rifampicin 600 mg, isoniazid 300 mg. So it all depends on what FDC that you have. So whether you have HP, I think the program right now has 1 HP as an FDC of 300 mg isoniazid and 300 mg rifampicin, but the additional dose of RFP rifampicin has to be given 300 mg, and again uh, depends on the number of pills. I mean, depending on the dosage, the number of pills changes. So you can see the number of pills that needs to be taken if you have an FDC of HP FDC. So then rifampicin 300 mg. So you will be having 2 pills. Okay. Then rifampicin is only 150 mg. Then you have to take 2 pills there and one HP FDC of 300 plus 300. That becomes 3 pills. If the rifampicin available is 300 mg, then you have to take 3 pills of along with isoniazid 300 mg. So likewise, isoniazid 300 mg plus rifampicin 4 pills. So it all depends on what supply is being given to the centers, okay, under the NTEP. So along based on that, we have to adjust the number of pills for the dosage of 1 HP. So 6H as a treatment option. So isoniazid, the known that we are all aware, the 6 months of isoniazid treatment has been there till the revised guidance on TPT has come into place. Okay. So once daily for 180 days of 6 months. So it's safe for use in the pregnant woman. No interactions with the ART, and it's best observed on an empty stomach up to 50% reduction in the peak concentration with a fatty meal. So who are eligible? All PLHV less than 30 years, pregnant and breastfeeding women, okay, living with HIV, PLHV who are based on the PI based ART. 4 again we are saying 4 months of rifampicin once daily, okay, for 4 months. So interactions, pregnant, no safety or efficacy data available specifically in this population. So we don't go for the 4R in the pregnant woman. So interactions is contraindicated in all PIs, nevirapines and most NRTIs and TAF. Adjusted dose is required with DTG and raltegravir. No dose adjustment required with the tenofovir or F average. Absorption is rapid but may be delayed or decreased by high fat meals. So eligible population, PLHE contact with INH resistant and rifampicin susceptible TB patients and who are not on a PA based regimen. Dolutegravir dose needs to be adjusted to 50 mg twice daily when given with the rifampicin. We have seen in the earlier slide, it has to be continued till 2 weeks of completion of the ATT. So dosage, age more than 10 years and older, it's 10 mg per kg. For less than 10 years of patients, it's 15 mg per kg. And maximum dose of rifampicin will be 600 mg per day. 6 levofloxacin as a treatment option. 6 months it has to be given for 6 months and once daily. Levofloxacin tablet has to be taken. So you have 180 doses in that. Pregnant women safe. Interactions with ART, no interactions with the ART. Who are all eligible? PLHV contact, who are having contact with MDR TB patients and rifampicin resistant but fluoroquinolone sensitive and who are not on PI based ART. So dosages, we have mentioned age for more than 14 years by body weight and less than 15 years, range approximately 15 to 20 mg per kg by body weight. So you can go through the table mentioned in this slide. So how do we actually monitor the outcomes of the TPT? So when you talk about the initiation of the TPT, so after ruling out active TB disease, the TPT is initiated and appropriate TPT regimen dosage should be prescribed as recommended by the weight band. Counseling needed for the TPT, schedule of medication, timing, follow visits, and any adverse effects by the counselors. PLHIV should be advised to report back at the earliest if they have persistent nausea or loss of appetite for more than a day for evaluation of liver function test. Any new onset of worsening of the symptoms. So PLHIV who are initiated in 1 HP, entire course of 28 should be given along with the ARV drugs at the AT center. PLHIV initiated on other TPD regimens, 1 month doses along with the ARV drugs are requested for a monthly follow-up. So the most important point is that the 28 days course is a very 1 month course. So the patient has to be counseled for adherence of these medications, completion of the course for 28 days. So they have to take along with the ART. So that is the most important thing. And follow-up of these patients for these 28 days, because this is a very short course TPT regimen. So they have to be followed up continuously for 28. So that is the most important thing. So other regimens, so 6 months, so they have to be followed up, and the date has to be realigned along with the ARV drugs. So any Nikshay Sampark, there are NTEP helplines and NSCP helplines. So the patients can actually be made aware of these available toll-free numbers, so which they can contact it. So you can actually post it in the patient's waiting area for any support needed in terms of the TB or the HIV. So how do we monitor? So PLHIV receiving TPT should be monitored at every contact with the healthcare provider. So again, the patient has to be screened for forest screening and the adverse effects. It's not that the patients who are in TPT should not be screened, but every patient again has to be screened for the forest screening. So in case of any signs or symptoms or TB are present, they should be immediately referred for the NAT testing or the DMC. And if found positive, the TPT should be stopped and appropriate ATT should be initiated based on the drug sensitivity testing. So the decision to modify or stop TPT drugs or to restart must be taken by the ART medical officer with the clear history and counseling of the patient. So why whether the how to why the modification is being done, why the drugs are being TPT are being stopped. So whatever the information that the decision has to be taken by the ART medical officer. So the treatment completion on this one, various TPT regimens. So 80% of the recommended dose consumed with the treatment duration plus 33% additional time. So this is what is the planned TPT completion or TPT duration. So looking at the different regimens, so the patients are, whether the patients are on 1 HP or 6H or 6LFX or 4 hour. So how do we ensure that at least 80% of the doses were taken? Okay, so we look at the duration in months, the number of doses that we discussed earlier, that each regimen, how many doses will be there. So what could be the 80% of the recommended doses and extended time for the treatment completion. So this is how you monitor whether the treatment completion has been achieved by the patient or not. We talk about 1 HP, so we know that there are 28 doses out there in that. So when we say 80% of the doses are recommended, so at least the patient has taken 23 doses. Okay. So what has to be done for the dose needs to be completed. So the number of treatment completion days, which is 33% additional time. So they have to complete the rest of the dose within that particular period. So likewise for the INH, likewise for the levofloxacin, likewise for the 4-rifampicin. So this is how the 80% and the time, that is additional time that is needed for the planned TPT duration, that needs to be completed during that particular period of time. So this is the most important table. So for the medical officers to keep referring to this whenever the patient on TPT comes to you, they say that they have completed this many dosage and what time, additional time is needed for you to ensure that the patient is going to complete the rest of the additional doses. So you can please take out a printout and keep it on your table for easy reference. So how do we manage the missed doses? So if the regimen is 1 HP, the date of the duration of the interruption is less than a week. Okay. So if more than 23 of 28 doses, 80% or no action is required, just complete the remaining doses. But no, they have to complete the remaining doses as per the table shown in the earlier slide. Okay. If less than 23 of 28 doses were taken, resume TPT immediately and add the missed doses to the total treatment to complete a course within a maximum of 6 weeks from the first dose, right? If the duration of interruption is more than 1 week, so if the doses, 7 doses were missed intermittently, so here look at the word intermittently. So resume TPT immediately and add the missed doses to the total treatment duration to complete the course within a maximum of 8 weeks from the first dose. If more than 7 consecutive doses, so look at the difference between the intermittent and the consecutive doses. So consider, so if the patient, we say 7 doses were missed intermittently. Here we are saying consecutive doses were missed. consider restarting the complete course of 1 HP. That is most important. So the patient is missing intermittently, then you have to ensure the resume the TPT immediately and complete the course within maximum of 8 weeks from the first dose. Okay. If the patient is missing 7 consecutive doses, then you have to restart the complete course of 1 HP. If the adherence up to 1 HP is not possible, consider discontinuing it. Again, we said the medical officer will take a decision whether to continue or discontinue it, and then appropriate regimen, what is needed, then the medical officer will decide. Okay, an alternative daily regimen will be prescribed. So likewise, 6H, 6LFX in 4 hours. So if the duration of interruption is less than 2 weeks, resume TPT immediately upon return and add the number of days missed to the total treatment duration. Do not change the scheduled date of next follow-up visit, but the last follow-up visit will be postponed by number of extra days to compensate for the missed doses. Example, if a child on 6H has missed 3 days of treatment, continue TPT for the duration of 6 months plus 3 days from the date of the start. So you have to give the additional dose of that particular 3 days from the start of the TPT, right? If the duration of interruption is less than more than 2 weeks, okay, and the treatment interruption occurred after 80% of the expected doses were taken, continue and complete the remaining treatment doses in the course. If less than 80% of the expected doses were taken and the treatment course can still be completed within the expected time for completion, example, if the treatment duration plus the 33% of the additional time, continue and complete the remaining treatment doses in the course. If the 80% of the less than 80% of expected doses were taken, the treatment course cannot be completed within expected time of completion, consider restarting the full TPT course. So this is about your 1 HP, 6H, 6LFX and 4R. How do we actually manage the missed doses, whether to restart, whether the patients have missed intermittently, whether the patients have missed consecutively, okay, what percentage has missed. So based on that, we have to take an appropriate step of whether to restart or continuing the rest of the treatment within that particular additional time. Okay. So coming to the most, I mean, again, we are seeing the treatment part of it, diagnosis part of it, symptom screening part of it, and coming to the TPT part of it, CPT prophylaxis. Not much mentioned about CPT prophylaxis in these slides, but I think assuming that the ART medical officers are aware that no, along with the ATT, that the CPT prophylaxis has to be given during complete course of the TB treatment. Not much was no discussed about CPT prophylaxis, their dosages among the adults, adolescents, and children. But this has been covered in a number of times in the previous sessions. So not discuss much about it. But again, so CPT, then we talked about the TPT part of it. And the last most important part is the airborne infection control or the ART center, what precautions have to be taken. Okay, and how to ensure that the fast tracking has to be done. Okay, what could be the airflow direction and how the distance has to be maintained between the patient to patient, like always on the airborne diseases. So what care has to be taken. So this is the last important few slides on airborne infection control. Okay, so the national guidelines will be stressing on the airborne infection control in healthcare and healthcare setting, especially at the ART centers, as these are the high risk areas for the airborne transmission of the tuberculosis. Okay, since we know that you can see the high load centers, you have to see like a number of centers that on based on the load of the ART centers, the high load centers. So you can see the crowd during the OPRs. So who are no, this is the where actually the importance of your forest screening comes into picture, and fast tracking of those patients will has to be done. Okay, so to avoid this basically, and know what measures have to be taken. Okay, and we know that they are all vulnerable to TB infection and later develop the TB disease. So with such high burden of TB patients in the proximity to large numbers of vulnerable patients, the probability transmissions are very high. Okay. So furthermore, then we have the environmental factors may add risk to the spread. So particularly, as we said, the crowding is there, the ventilation is inadequate, or recirculating air conditions are used. So some of the ART centers will be like the closed room with the air condition on, with no minimal or no ventilation. So it is very easy for no the even the ART staff to get infected with the TB. So, considering this high burden of tuberculosis in India and the transmission risk for the healthcare risk of healthcare respiratory infections, like as we discussed, like the COVID-19, the recent COVID-19, and the very common influenza. So, this has become the most important. The airborne infection control becomes very critical to be implemented at the ART centers. So this is the hierarchy of the AIC measures that needs to be taken. So this is adapted again from the operational guidelines. So what measures have to be taken at different levels? So managerial level, what measures, administrative level, what measures have to be taken, and environmental level, and what PPE has to be worn by the healthcare workers. Okay. So if you look at the managerial level, so managerial controls, the formulation of the policies, establishment of the committees, and preparation and review of the AIC plans for each and every ward or for each and every OP room. And you have an HSCC committee, which we call this Hospital Infection Control Committee. It has to be constituted each and every hospital. So it will be there in each and every hospital. So you have any issues with your AIC, mean like no. So you can always reach out to the committee and say these are the issues at your centers. So usually it will be helped out. Not saying overnight this will happen, but it takes time since a lot of administrative approvals have to be given by the committee itself, by the hierarchy, right? So, and then coming to the administrative and environmental control measures. So, simple administrative environmental measures are aimed at reducing the exposure of HIV infected patients to the tuberculosis, which needs to be taken care by the administrative panel. And then the personal protective equipment, okay, so that needs to be worn by the staff at the hospitals. I'm not just confining myself to the ART center, but wherever the healthcare facility is there. So wherever it is available, so at least you have to wear the personal protective equipment like surgical masks to the patients, respirator certified as N95 it should be made available in the high risk institutions, especially DRTB centers and high risk aerosol generating procedures such as bronchoscopy and sputum induction. So wherever you see such places, then you have to ensure that the proper PPE equipment has to be there. And then the healthcare workers training, which is periodically CPs are to be periodically screened for tuberculosis as per the ASC guidelines of the government of India. I think very recently when NACO has taken up this particular screening of the ART staff now at our own centers. So this is also most important. Wherever you find difficulties, you have some difficulties in the AIC, please contact your HSCC committee and ensure that you have proper measures at your rooms. So this is again been taken from from our own the operational guidelines. So this is how the suggested patient flows should be there. Okay, you can go through this particular table which is there in the operational guidelines, and then the existing flow, and this is the suggested flow. So this is how the flow has to be there. Okay, patient flow has to be there, entry point to exit point. So this is clearly written. Okay, so this has to be followed, and how the ventilation has to be there for each of the medical officers of the counselors who are sitting there in the rooms, so closed rooms. So how the ventilation has to be there. So this is clearly given in this particular picture. See how the airflow has to be done. Okay, how the patient flow has to be there. So these are some of the simple measures that can be taken care to prevent the airborne infection controls. So coming to the recording and reporting, so every HIV-TB patient, as I said, has to be recorded in the HIV-TB line list along with the SOCH. So who are all responsible? SMO, MO has to record the diagnosis, treatment, follow-up company section 7 of the white card, and outcome also in the white card along with the HIV-TB registered by the staff nurse. So signs of TB and treatment card, and for the HIV-TB patients. For the by the staff nurse, so she has to maintain the HIV-TB line list along with the HIV-TB register. Okay, and prepares the TB treatment card for the HIV-TB patients, and the treatment card has to be handed over to the patient for documentation of adherence and follow-up in the field. Okay, and she also maintains and completes the TB treatment card. For the data manager, so the entire data has to be entered at the center's MLL and the SOCH, so which is most important, including the TB treatment outcome. So this is where I was stressing. So most of the times that we miss out is documenting the TB treatment outcome, whether it is in the HIV-TB register or in the SOCH. We for sure will enter either in the MLL or in the HIV-TB register the date of the start of the ART, date of start of ATT, their CD4 count, even now the revised one, the date of the viral load testing part of it, and the missed part here when we talk whether it is in the SOCH or in the HIV-TB line list, it is the TB treatment outcome, which will not most of the times we miss out on this. So please try to document even the TB treatment outcome in the SOCH and the MLM. And data manager will also look in the enrollment, the NICSHI, generating the NICSHI ID. and the TB treatment outcomes in the NextShift portal apart from our own Soch portal. So line list, as discussed, has to be generated, auto-generated from the Soch. So soft copy in the MLL has to be maintained on the ART centers, and information on the DRTB patients to be obtained from the STS in details completed in HIV-TB line list. And the soft copy has to be maintained for each financial year because the TB treatment lasts for 6 months only. So it may be extended for another few weeks or months. But this particular financial year, the HIV-TB line list has to be maintained based on for each financial year. Okay. HIV TB register again auto generated from the source by the financial year. So TB laboratory referral form. So it has to be used referral for the PLHF for TB testing to a NTEP facility. TB treatment card to be maintained for PLHF and TB treatment, and duplicate copy not required, and okay, and it has to be kept at the ART center. So this is how you have to document in the green book and to be updated by the SMO MO in the green book. Soch, so the most important, how where it has to be updated in the Soch by the data managers. So you have to again document apart from the TB treatment, you also have to document the TPT part of it, start date, stop date, restart date, and end date. Okay. And TPT status, you have to update it, no, completed, not completed, or lost of follow, but the patient has died. So this status also has to be updated in the search portal. So these are the important documentation that needs to be done at the ART center level by the data managers. So this how you have to document in the TB treatment in the white cards, TPT initiations in the white cards, okay, and TPT in the section 8, the revised ones. Okay, the revised white cards, please look into the revised white cards. So some of the ART centers still using the old white cards, please look into the revised white cards and document this in the section 8A of the tuberculosis. Okay, and white card section 13 where you have to update all this in the section column 8. Okay, so this is the end of the session on TPT. Thank you everyone for your patient listening. So any questions, you may please
Thank you so much, sir.
take it up.
Yeah, thank you so much for facilitating this important session, sir. Kiran sir, just wait for giving mic access. We'll cover these questions from the chat box first. Sir, please allow me to share my screen. If you can stop sharing,
Yeah,
please.
sure.
Yeah, hope the screen is visible, sir.
Uh, okay. Yeah. About
Yeah,
the patients with TPTB lymph nodes are microbiologically detected to be followed. So can anyone elaborate that question? So what do you mean by the patients? Yeah, EPTB lymph node TB is there, microbiologically detected to be followed. Mean since what? So someone who has raised that question can give the mic access and maybe elaborate that question.
sure, sir. I'll give mic access. Till
Yeah,
then, if
weight
you
band
can
for
go
the
ahead.
ATT
Yeah,
revised. I'll take up the other question. So the weight band for the ATT revised recently. Yes, it has been revised. Please look into the NDP guidelines also, our own guidelines. So it has been, these are the recently revised weight bands. So can we start IPT 6 months for PLH of completion of the secondary prophylaxis is not needed for I covered this. So if you're talking about the IPT part of it, so secondary prophylaxis after completion of TB treatment is not needed for adults more than 13 years. In case of MDR history, if you don't know if it was resistance or INH, no information available. We just getting information the patient was taking DRTB treatment, how to consider a TPT. So maybe we'll leave that question to the participant who has raised that. Earlier, patient was offered 6 months. Whether it is IPT, okay, 6 months IPT, I consider it as INH. If she was IPT, LFU, she took only 2 months of IPT at that time. Therefore, IPT is not complete. Shall we offer 1 HP now? I think there are the special situations which actually we didn't cover it in this particular session because there are around 20 to 30 slides on the special 20 to 30 points that needs to be covered. So we actually, because this was covered in the last NDLS session. So IPT treatment was not completed. Shall we offer 1 HP now? The patient who has taken INH has to be completed the INH part of only. Maybe I can look at that specific point. Maybe I can take post that in the physicians group. Okay, he cannot be now shifted to 1 HP. He has to be completed on the INH because he has took only 2 to 3 months, and after that continuous the patient has not taken. So consecutively, patient has not taken INH. So he has to be given INH, not the 1 HP. So can we take CD4 count and viral load during TB treatment? Patient is unaided. Otherwise, we have to wait for the completion of see, the patient is due. See, you are not relating this anything with your viral load testing dates or the CD4 testing dates. Okay, why we say is there might be chances that there might be a bit of lab reporting, there might be ups and downs. So usually we say that wait for the treatment to complete, no, let the patient be normal. Okay, Naito will have difficulties in analyzing, interpreting those results. So if the date is due, the medical officer can take a decision. So the patient treatment is intensive phase or a continuation phase. Okay, but suggested is if at all, if it is again the medical officer's discretion. If the patient has to undergo a CD4 viral load for some other reason, if the patient is on treatment, supposedly this decision can be taken by medical officer. But there might be possibilities. Some of the studies say that there might be interpretation might be different in when the patient is on undergoing, because the patient is already infected with TB. So there might be ups and lows in the values. So that's one of the studies stays. Some of the studies stays. So always go to complete. If it is not an emergency, okay, you can wait for the completion of the treatment. Or you think that no, the viral load testing is due, the patient has no, we have to suspecting some other, we are suspecting some other treatment failure, then we have to undergo a testing. Other questions, please.
Yes, sir. Dr. Sumita ma'am, if you can please unmute. Dr.
Good
Sumita
afternoon,
ma'am.
sir. Yeah, I have.
Yes, ma'am.
Good afternoon, sir. So, regarding the first question, I mean to ask if the patient has been detected lymph node positive TB on TrueNAT,
Okay.
how are they to be followed, sir? Further, I mean, we do not take them up for sputum. Now, after 6 months, if they still have a residual swelling, I mean, lymph node swelling, if we refer to the ENT surgeon, they usually keep continuing, give 1 month more, 1 month more, 1 month more, like this, sir. So, how long should we?
What needs to be given 1 month more, ma'am?
ATT is extended. I mean, they keep extending the ATT on the monthly basis, sir. Even after 6 months, if we refer the patient to ENT surgeons, I mean,
No, why the
how are,
patient is referred to the ENT surgeon here, ma'am?
no, sir. After 6 months, even if the lymph nodes don't resolve,
No. See, why do see lymph node not resolving is fine, but no. What does the see whether the patient has responded to the treatment? So once the patient has completed treatment for the EPTB, which he here in this case is a lymph node TB, right?
yes,
So
yes,
what
sir.
did I have covered in the slides. So what needs to be done when the patient has completed treatment? Okay, whether the patient is cured. So how do you do that? If it is a lymph node TB, then again you have to do an FNAC, right?
Okay, sir.
Okay,
Fine.
FNAC करने के बाद, if the patient is cured of TB, there are no bacilli found, then the patient, that means lymph node resolve में time लगेगा शायद, most probably, okay,
Okay.
but the patient is cured of TB, okay, by any of the tests, okay,
So we do a
we
repeat
don't need,
FNAC,
yeah,
sir, at the end
we
of the
don't,
treatment.
yeah, see, for this case, we don't need a CBNAT testing here, right, because it's an EPTB. We
Fine,
don't
sir.
need a sputum testing. We don't need to refer the patient for DMC. This is an
Yes, sir.
EPTB. The patient has been initiated an EPTB treatment. Okay, TB treatment, ATT. Okay,
Yes, sir.
and
Yes, sir.
completion of the treatment is there. And after the completion, okay, then the
Yes, sir.
patient underwent an FNAC to see that it is completely cured. So forget
Fine.
about resolving or not resolving. If the doctor, see, I'm not uh, here because you said the ENT surgeon के पास भिजाए patient को, but
Yes,
in
sir.
case the patient ENT doctor, I mean, because it has to be taken care by a known physician, right?
Fine,
Okay,
sir. Yes,
and
sir.
then based on that, a appropriate call can be taken. Do we need to continue the medicine? That is the question. By needs to be taken by the TB physician, not an
Okay, sir.
ENT physician, ENT
No, sir,
surgeon,
the
right?
physician only refers to the ENT surgeon.
No,
That's the case.
I'm
Like
not.
we have 2, 3 cases of lymph node TB, sir, neck lymph nodes, and
Yeah.
they are not resolving, sir. So they are taken care by the ENT surgeon. Even if I refer to the physician, they refer to the ENT surgeon. So they have been extending. One
I
of
think
them is nearly
fibrous,
9
see,
months of
some
treatment.
reasons why it may not, they may not be resolved is fibrous formation of the lymph nodes might be there, which might take some time. So I think the best persons are to rule out whether to continue the ATT for another few months without doing an appropriate test to rule out whether the bacilli, whether the treatment is completed and the bacilli are not no more seen or TB is ruled out. Okay, there is no point in extending the treatment, right? So
Okay.
I think it all depends on how the chest physician or a TB physician will take a call. Resolving for sure depends on many factors.
See. Okay,
Okay.
sir. Thank you, sir.
Thank you so much, Ms. Sonitha.
Okay, sir. Good afternoon. Myself, Dr. B.N. Tripathi
Sir
from
Tripathi sir, how are you,
Center.
sir? Tripathi sir, how are you?
Sir, my question is on the slide where it was written that secondary prophylaxis is not necessary. I could
As
not
per the
follow that
revised,
actually.
as per the revised guidelines, sir. Previously, when we secondary prophylaxis, so is not needed for the adults more than age 13 years. So it is not needed. You don't need to give a secondary prophylaxis because secondary prophylaxis, where do you give the secondary prophylaxis, Tripathi sir? Where do we usually give? Where do we usually give?
Even usually there are other diseases are there like a PCP.
No. Think of only the TB part of it, Tripathi sir. So one is your primary prophylaxis where we are giving to prevent the TB, right?
After treatment, completion of
So
treatment.
yeah, completion of
If
the
we
treatment.
continue to
Yeah,
give prophylaxis, then it is called secondary prophylaxis.
absolutely, sir. So once we are starting with the patient before the TB, before the once we start the patient on TPT, that is the primary prophylaxis, ruling out the 4 symptom screening, right?
Sir.
So you are saying the patient, suppose during the course of the TPT, the patient has developed TB symptom, TB diagnosed. So we start the TPT. Okay. Now you look at the age of the patient, whether the patient has no less than 13 years or more than 13 years. So now the TB treatment is completed. Now you want to start the secondary prophylaxis. Okay. Now you want to start the prophylaxis. So the patient is more than 13 years, adult and adolescent, you don't need to give secondary prophylaxis. The patient is 13 years old, okay, children, then you have to start the secondary prophylaxis for these patients.
Sir, this is applicable for both TPT and 6H.
It is TPT, sir. We are not talking about the regimens here. We are talking about the TPT here. So TPT may
That means
TPT.
both
Yes, sir.
the
See, when you talk about tuberculosis preventive treatment, under that you have all these regimens, which is 1 HP,
okay.
you have 6H, you have 4R, you have 6LFX, right? So these are all the regimens under your tuberculosis preventive treatment, and for which under each regimen who are eligible patients. So based on that, we give the prophylaxis. Okay.
Okay.
Whether it is a primary or a secondary.
Okay, thank
Sir,
you.
Tripathi sir, thank you.
Any
Good
more
afternoon,
questions?
sir.
Yeah, ma'am.
Good afternoon, sir.
Yeah, ma'am, please go ahead.
Hello.
Yes, ma'am,
Ah,
please. We can hear you, ma'am. Please go
We
ahead.
have given primary prophylaxis for a child less than 13 years. Child gets tuberculosis after 1 or 2 years. Do we have to give secondary
Ma'am,
prophylaxis
one
again
second.
after completion of ATT?
1 second, ma'am. You said you have given 1 HP,
Primary
right?
prophylaxis.
1 HP or 6 and
No,
6
sir.
INH?
Less than 13 years means 6H.
Yeah, 6H. 6H you have given. Okay, fine. For children, right?
Later, the child develops tuberculosis. Yes,
So
child.
later
Child
in the
of 4
sense,
years.
a
Let's
child of 4
take
years,
it.
absolutely. Fine. So here in
After
this
2
case,
years.
yeah, fine. So the patient here, less than 4 years, you have started him on weight-based regimen of 6 months of INH.
6H.
Okay, 6H. Okay, and the patient has the child has completed the treatment, right? Right?
Yes.
So completed, right? 6 months.
Yes, sir.
And after completion, later after 2 years, the patient has developed TB.
Yes, sir.
Okay, ma'am. Fine. So
Yes, sir.
once the patient has completed the course of TB treatment and now is no treatment outcome is cured, okay? Right?
Yes, sir. Yes.
Now, since the patient is
Yes, sir. Yes.
since the patient is less than 13 years, you can always go for the secondary prophylaxis. Okay,
Okay, sir. Okay, sir. And what about starting ART and TPT at the same time? Does it not cause pill burden, or if at all there is any hypersensitivity, we will not be knowing whether it is due to CPT or TPT. Can we not start TPT after a month or so?
Guidelines usually say start both at the same time because we don't have much of interactions, drug-drug interactions, or much of a known adverse effects for both ART and ATT, ma'am. So we don't need to worry. I'm not in general, not for this particular patient that we just discussed. Okay, but if
No,
you talk
not for
of
this particular
yeah,
patient.
yeah. So you have to start both ART and ATT, I mean the TPT at the same time, ma'am. We don't have known drug-drug interactions or no any adverse effects
In
as per the regimen that we use, the
general,
TLD part of it.
in general.
In general, ma'am, in general, no.
Uh,
You can just go through the slides that we have just shared now. So drug-drug interactions, if at all any, there it will be very minimal, okay,
Yes.
and
Thank
which will not be
you.
not worrisome.
Sir, Dr. Tripathi again.
Thank you, sir.
Yes, sir, Tripathi, sir.
Sir, we patient is on dolutegravir-based regimen and we are giving 1 HP. Should we give extra dolutegravir to that patient?
Sorry, sir. Please come again.
Patient is on dolutegravir-based regimen. And
Yeah.
we are giving a TPT with 1 HP. Then should we increase the dose of dolutegravir? That
No,
will do
nothing. We are
like
not
in
mentioned.
ATT.
No, we are not mentioned that, sir. Your additional dose of dolutegravir is needed for the patients who are on TB treatment, who are receiving rifampicin-based regimen. Okay, with the patient is already there on the dolutegravir-based regimen. For these patients, an additional dose of DTG 50 mg is needed, which has to be continued throughout the course of the TB treatment and to be extended till 2 weeks after the completion of the TB treatment. But there is no additional dose of DTG that needs to be given when the patient is on TPT regimen.
Okay. Thank you.
Okay, sir. Thank you, sir. Dr. Prema, medical officer, the PLHV completed IPT 5 years ago. Can patient the TPT prophylaxis has to be given only once in lifetime, ma'am. So it cannot be repeated unless the patient has interrupted the treatment of the TPT.
Thank you so much, sir.
Thank you.
Sir, one more question.
Yeah.
Due to shortage of IPT stock, 6H, many patients who were on 6H we were not able to provide them enough drugs for the period of 6 months. We have many such patients who have received only for a month or so. Should we start them on TPT?
This is more of an programmatic and administrative question that needs to be answered, ma'am. So initially, if you remember the OM that I was showing in the slides.
2016 and 17, sir.
No. I'll tell you my own explanation for this thing, ma'am. Because this is basically purely a programmatic decision that needs to be taken. Okay. So that's the reason why when I'm showing the OP, I was clearly saying that the ART center has to calculate how many people are eligible for TPT or IPT. Okay. And now the IPT, we have to categorize the patient. So based on that, whether do we have enough stock for me to start a patient on TPT? Suppose I have 100 patients who needed IPT or TPT. Okay. Example, I'm telling you. And I have a stock which is good enough for 50 patients only for rest of the 6 months. Or if I talk about 1 HP, I have good enough stock for 50 patients. Okay. So I will not initiate the rest of the 50 patients on 1 HP because I only have good enough stock for only 50 patients. So I only start those patients. I will not start rest of the patients. You take 10 tablets, you take 10 tablets, you take 10 tablets, which should not be done unless you have enough stock for 6 months, good enough for all your PLHV who are initiated on different regimens of your TPT. Then only you start the patient on the TPT. If you don't have enough stock, suppose I have one patient who is on 6 months of INH, 6H, okay? So I need 180 tablets of 6H for this particular patient. Do I have enough stock? I should not split this stock between 10 patients. Unless you have that stock, please do not initiate the TPT because the patients who have taken only 1 month are remaining idle for the rest of the 3 months till you get another stock of the dose. That means you have to restart the patient again on the regimen because there is an interruption of more than months together for these patients. The stock analysis is most important. Eligibility is most important. Based on the stock available, based on eligibility on different regimens, I calculate how many patients need to be initiated who can complete the course, whether it is 28 days or 6 months or 4 months. So this is how the calculation needs to be done. If at all your center has initiated many people during 16-17 who have not completed, please restart them again. Clear,
do we
ma'am?
have to start them again, sir?
You have to restart because they have
Uh,
only completed 1 month of
yes, sir.
TPT.
Yes,
They
sir.
have only completed, that means
Yes, sir.
they have not completed full course. Please follow the
Mm,
guidelines which are there in our operational guide
mm,
in the treatment guidelines. Look at the
mm.
specific case scenarios. How do we manage the patients under different regimens of TPT?
Yes. Thank you, sir.
Who actually
Thank
miss
you.
the doses? Okay, ma'am.
Good afternoon, sir.
Yes.
Yes, ma'am. Thank you so much.
Sir,
Good afternoon, sir.
Dr. Tripathi again.
Ma'am, I can't hear
Yeah,
Vinoda, ma'am. A
yeah,
lot of
yeah,
disturbance in the background noise.
yeah. Good afternoon. I think, can you hear now?
Yes, ma'am. Please go ahead.
Yeah. If the TPT doses have been taken 4, 5, 3, and if they are discontinued within 9 months of the initiation of the TPT, we can definitely complete the extra doses.
I can't hear you clearly. A lot of background noise, but if at all I can make out, I answered that in the
Yeah,
previous question.
yeah.
I I
Yeah,
answered that in the previous question. If the patient has not discontinued the medicine, they have to be restarted again on the TPT regimens.
yeah.
And if at all, see, intermittent discontinuation or a consecutive discontinuation has to be documented. Okay. And I've shown you the table, one of the slides where the amount of so a lot of background noise, ma'am. Anyway, I'm trying to answer that question. So you can
No,
look at that particular slide. There are different regimens of TPT. What amount of medication has been taken? Okay, whether they have completed or not. If at all intermittent discontinuation, how to complete that? If at all a long-term discontinuation, there, how to complete that? So do you have to? If at all there is a
that is
gap of
very,
more 80, you can. I can't hear you,
that
ma'am.
is,
Maybe you can mute, ma'am. You can mute. You can mute. I can talk. Yeah, yeah. So if at all, I explained that in the previous query raised from Yati Center Tumkur, the patients are discontinuing, then you have to look back what has been explained in the earlier slides, what time of discontinuation is there, continuous or intermittent, then based on that, the decision has to be taken. Like I said in the previous question, only 1 month has been taken and they have discontinued for months together. That is, you have to restart the patients on the TPT regimen that he was there previously, not go on for the new regimens. Please remember, you should not start them on the new regimens. You have to continue with the regimens that they were on previously, what they were started. Yeah, thank you, ma'am. Vinodha, ma'am.
no,
You can mute, ma'am. There's a lot of disturbance from your side.
yeah. Can I ask one more question, sir?
You can put it in the chat, ma'am. I think that's easy because a lot of background noise here.
Yes.
Sir, we'll wait for
Yeah.
Dr. Vinoda ma'am's question in the chat box. Kiran sir, we can discontinue mic access for now. Due to time constraint, we won't be able to take additional questions. Please feel free to write to us and
Yeah,
we'll see that those
physicians
are
group. Yeah.
answered. Yeah.
Yeah.
And yeah, we can put it in the HIV physicians group also.
Yes.
Sir,
Yes.
last question for today from the from the chat box. There are two questions now.
Yeah.
If a patient comes transfer out but does not have any record maintained in the white card and he's also not able to explain it properly, what should be done? And yeah, and then there's one question from Vinoda ma'am. What are the side effects of TPT?
Yeah, I think it depends on the regimen that we are using. So it was explained in the slides. So what side effects could be there based on each regimen, whether it is HR, okay, HP or R or levofloxacin. So you may please go through those slides, ma'am.
Right, the PPT will be shared soon.
Yeah. That question, I think documentation is not that is most difficult part. The patient has been transferred out. So you have to contact that particular ART center, get back their HIV-TB line list registers, white cards, green book of that particular patient. Say, see what has been documented and what has been missed out. So that is most important. So you have to, because this is most important, and the TB patient. So we have to take care of the particular patient who has been transferred into our own center. And patient will not be able to explain properly because if that is not, that's the reason why we say documentation is more important in the green book and the white card. So that is not being done at the ART center. You can always talk to the medical officer there why the documentation is not there, because you are referring a TB patient, not an ART patient with no 1 or 2 regimens with no multivitamins and one ART. It's not that. You are referring a TB patient and without the history of what regimen the patient is, what type of TB case that is, whether it is a PTB or EPTB, right? and how it has been confirmed, what regimen has been initiated, what drug resistant, drug resistant. If these details are not there, it is very difficult for us to follow up that particular patient. So it is always better to get back to that ART center and try to get what are the maximum possible information that can be documented now at the ART center.
Thank you so much, sir, for the extensive session.
Thank you so much.
We do
Secretary.
have some questions in the chat box, but I'll share it with you later, sir.
Okay.
Yeah, thank you so much, sir.
Thank you so much, and thank you everyone for
Yeah,
the
we
patient
have been
listening.
receiving messages in the chat box that they are very grateful to you for this session. So thank
Okay.
you for that.
We'll take up that in the physicians group.
Sure, sir. And
Sure.
Kiran sir, can we quickly run the feedback form? Thank you to all the participants for patient listening and waiting till the end. Just 2 more minutes. Please fill in the feedback poll. You just need to answer 5 questions and click on the answer of your choice. The recorded link and the PPT will be shared with all the ART centers later.
There's a confusion between strongly agree and strongly disagree.
Yeah, that question,
That question,
that
the question
question
has
is
to
a bit,
be
we'll have to reframe it, sir.
rephrase that. Strongly
Yeah,
agree. I guess I think
yeah,
they're getting confused. So agree and disagree. So tuck 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 tuck,
right,
like
right,
poll.
right. Yeah,
They're putting it
yeah.
in.
For those who would like to go through the recorded links of the NDLS and the RDLS sessions, I have put the YouTube channel. You can subscribe to the channel and you can watch all the NDLS and RDLS sessions on the YouTube.
So can we start TPT in paralytic patients? Why not? We can start after pneumonia gap. After pneumonia gap of how many days for TPT initiation? I'm not sure about this because after pneumonia, if the patient is completely recovered, I think we can start the TPT immediately. For the patient is already suffering with pneumonia, the treatment led the because depends on what type of pneumonia the patient has been suffering, and we have to see or we can take a gap because the patient is assuming the patient is PLHA with a pneumonia. We can wait because that will not be an emergency immediately to start one thing. And if at all needed more clarity, I think we can contact the treating physician. Can we start? Can we give TPT? So it depends on regimen that we are using because already pneumonia, TB patient with pneumonia, we are not sure. If it is sorry, it's not a TB patient, a pneumonia patient. So we can. I think a better option can be discussed with the physician. Yeah. OM not giving the OM on not giving secondary prophylaxis was above 13 years. Yeah, that is the OM. It was not mentioned. It's there in the TPT guidelines. So we'll share it through the NACO. So we'll discuss with NACO to send that particular information. Patient Karasarota, we have discussed this. None of the PVL. So that's what I said. So unless necessary, the viral load can be delayed bit till the treatment completion because once the TB is there, then there is chances of bits and bleps will be there in the viral load count.
Regarding
Yeah.
the YouTube channel is hosted by iTech India. However, the sessions are owned by NACO. So NDLS and RDLS sessions, both are a part of NACO program.
Okay. Thank you so much. Thank you everyone for the patient listening.
Thank you, everyone.
Thank you.
Kiran sir, we can end the poll now.